let's talk about therapeutic communication. So communication consists of all critical thinking, depends on the quality of communication, mutual exchange of information, developing your communication skills, which is as important as developing clinical skills. You got to know how to talk to somebody. You got to know how to not take things personal, keep control of your voice, etc. Because you're going to run into some, you guys already know this, some different kind of people sometimes. So communication is huge. Without proper communication, we can't get our patients to follow the plan of care that we've worked out together with them. And that's what we need to help them get better. So the communication process, you can see that I've got a nice little diagram that came out of your book here. And it says the stimulus or the referent, this is how this is going, could be the patient, their need, such as a feeling of discomfort, or say they wanted to have some information. So that gets the ball rolling. The sender or the source of the message, which is the encoder, begins the communication process. This is all technical now. The message itself, which is the actual communication product from the source, and some examples of what a communication product would be speech or an interview or conversation, chart, gesture, nursing notes, etc. That's our communication piece. That's the message itself. Okay, the channels of communication is called the medium, and that is selected to send the message. So I might use auditory, which is the spoken word and cues, or visual, which is sight, observations, perceptions, kinesthetic, which is touch. And I am a huge toucher. So even recently, when I had a person here in my house, I was having some work done from a water heater that had been running over for who knows how long. Here we are, all keeping ourselves socially distanced, and then what I got to do, I got to smack him on the arm. It's been very hard on me. So nurses use all three of these channels to communicate. This nurse definitely does. So the receiver of all this information, I'm sending it out. I'm the encoder. I'm sending it out. The receiver, that's you. You're listening to me now. And see, our medium is a PowerPoint that is narrated. So the receiver or the decoder must translate and interpret the message sent and received. The receiver makes a decision as to the accurate response. So you decide after you hear what I have to say how you're going to respond. And feedback, then, is the confirmation of the message that the receiver has understood the message. So when we meet up for our class, and then I discuss with you, did you have any questions over this PowerPoint? And then if you respond to me, that'd be the feedback, and that shows me that you've understood the message. So noise factors can distort and interfere with the communication process. So now, the nurse needs to be considerate of the receiver and select a message that appeals to the patient's interests. So you know what you could fit there is, you know how we learn nurse talk, and then we just talk that way because we don't know any better anymore. That's all we know. Well, then we get somebody who doesn't understand that language or those words, and you lose them right then. If you can't speak plainly to them, that's it. So let's see. And that requires, so we need to select a message that appeals to the patient's interest and requires minimal effort and time to decode, because they'll get wore out trying to decode it. Right now, I am hoping I will play this back, but and you know what, maybe I should play it back now. Make sure you can't hear the laundry. Forms of communication. First, we're going to start with verbal, which is language. So the exchange of information using words, including both the spoken and written work. That's verbal. Verbal communication depends on language, which includes common definitions of words and a method of arranging the words in a certain order. So for you and I to communicate well, it would help if we both spoke the same language, or at least both understood the same language. Let's see here. A person's use of written and spoken language forms reveals aspects of the person's intellectual development, educational level, and geographical and cultural origins. You can learn a lot from listening to how someone speaks, provided you're both speaking the same language. I'll tell you, when I was over in Europe, I could speak only a little bit of French, and they could speak only a little bit in the little town I was at of English. And so it causes you to think that person is dumb. But they're not dumb. You just have a language barrier. So let's see. We need to find out if somebody has English as a second language. That could make a big difference in how they're able to connect with us. Nonverbal communication. Look at all these different little pictures here. So nonverbal is body language. You can pretty much tell where somebody's at looking at their facial expressions or how they act. So nonverbal or body language is facial expressions, touch, eye contact, can be your posture. Have you ever seen somebody slumped in the chair because they're so sick of hearing talk about this or that? I'm thinking of my kid when he's getting some instruction from his mom. So posture, gait, gestures. What if you were dreading to go somewhere? I kind of think of a kid again, and they just drag their feet because they don't want to go. Gestures, if somebody's angry, they fling their arms all over the place. Or if they're excited, they fling their arms all over the place. General physical appearance. If somebody's terribly depressed, have you ever seen somebody like that? And their hair is maybe dirty, their clothes are dirty, they might have a body odor to them because they don't care about that stuff. They don't even think about it. They're so sad. Mode of dress and grooming, sounds, silence. All of those can be or are nonverbal communication. Eye contact or the lack of it, facial expression, posture, gesture. I just said all that. Silence sends nonverbal messages to the receiver. What messages do you receive from each one of these photos? Well, here, let's see. I think here on the upper left, he might be thinking about something. He might even be mad. In the middle, he looks anxious. What do you think? At the end, surprised, dumbfounded. The lower left, I'm not sure what that one is. Or the middle one, he might just be in deep thought. That middle one and the upper left look kind of the same. And then the two laugh ones. But you can tell a lot from somebody from just looking at them. Levels of communication. We have intrapersonal, interpersonal, and group. So intrapersonal communication is your self-talk. This self-talk can be positive or negative, and this affects the nurse's behavior as well as the patient's behavior. So, if I messed up, some days you just mess up getting out of bed, but say I'm feeling down on myself and I'm telling myself how stupid I am or what a klutz I am or this or that. Now, how do you think my attitude's going to be when I walk in there to take care of that patient? Or what if the patient's having a bad day? And lots of times that negativeness can rub off. So we have to be super, super nurses when we're in there and try really hard not to let that rub off on us and try not to let our feelings rub off on the patients. So that's intrapersonal, our self-talk. Then we have interpersonal communication, which occurs between two or more people with the goal of exchanging a message. And that could be me talking to physical therapy. I want to let them know how Mrs. Jones did on her walk today. Or me talking to the doctor. I want to let the doc know about Sally Smith and that she's not got enough pain medication. That's interpersonal. Then we have groups. There's small groups, organizational, and group dynamics. So small group communication occurs when nurses interact with two or more people, much like the interpersonal communication. But here now, look at the type of people. It'd be like a staff meeting, patient care conferences, teaching sessions, and support groups. Those types of communication between two or more people. Small groups. Then we have organizational communication occurs when people and groups within an organization communicate to achieve established goals, etc. Or, for example, like a practice council or quality assurance committee. And you've probably been in committees with had meetings wherever you worked at, groups. What am I trying to say? We have to be part of that kind of stuff. We have to be on committees. I guess that was it. Just plain old committees. So group dynamics helps determine the effectiveness or ineffectiveness of a group. It involves how individual group members relate to one another during the process of working toward group goals. That's group dynamics. So, factors influencing communication. Oh my gosh, look at this list. You can read through that. So let's just hit on a few of these. We got developmental levels. That directly correlates with the patient's neurologic competence and cognitive development. So the book gives an example of explaining an infection to a 10-year-old child is different than an adult. So the point is that you have to adjust your communication based on who you're speaking to. And then biological sex, your book says that men and women have differing communication styles and may give different interpretations to the same conversation. For sociocultural differences, nurses need to recognize ways in which culture, economic condition, and overall lifestyle influence a patient's preferred mode of communication. So depends on the cultures, and we've talked about this before. You probably remember this from the first time you went through. Some cultures, the men do all the talking. Some cultures, women are the boss. Some cultures, everyone is very shy. And we can't know everything, but we need to make an effort to learn as much as we can about different cultures so that we can communicate properly. Because remember what we said, if you can't communicate, if things aren't right in the beginning, people just shut you out. It's just a natural thing. So roles and responsibilities, I kind of already touched on that. A person's occupation might give a general idea of that person's abilities, talents, interests, and economic status. Don't stereotype, though. For example, assuming that a fellow healthcare professional knows everything about their condition and they don't need any or little nursing assistance, teaching, or counseling. Now, that happens to me a lot. When I'm going in, well, I say a lot. I have to be careful too, even when family members go in, once they find out you're a nurse. And often that can be just from the questions you ask, because the average bear doesn't ask the same questions that a healthcare provider asks. And they'll say, well, how do you know all that? And you'll say, I'm a nurse. Space and territoriality. People act differently in places they feel comfortable and safe than they do in areas that are new, such as a hospital room. So just think, if you're at somebody's home, they're going to be a lot more comfortable speaking to you than they are in the hospital. They're already freaked out that they're in the hospital, nothing's the same, they're sick, all those things come into play. Nurses act differently on their own floor. Think about that. Or in the area that they know really well than they do maybe in a patient's home, or if they get called off to another floor, floated to another floor. So we're always most comfortable in our own area. So that's just something to think about. If you got a patient that isn't answering your questions very much, maybe they're shy because of what's going on. Physical, mental, and emotional state. How comfortable a person feels physically, mentally, or emotionally affects their communication. And just think about that. What if I'm trying to talk to you and you need to pee? And you've needed to pee for an hour? Or your head's killing you, you're having a migraine, or you're worrying about something, you're filled with anxiety. All of those things can cause you not to hear me because you're so busy, preoccupied with the other thing that's wrong. So in cognitive impairment, such as aphasia, could keep a patient from being able to express pain. I think about my mom. My mom just died recently, and she had end-stage Alzheimer's, and she was unable to, she had a stroke. It would have been 2 years this summer. And it's funny because she could speak right afterwards. They gave her a clot buster, and she was back to talking like her regular demented self. And then just slowly that language left. So I don't know if, they never gave her any blood thinners after that either, which I thought was odd. She'd had AFib and then had been cardioverted and was never on any medication for AFib. So, she could have had AFib for a while, and I didn't even know it. But the point is that she got to where she couldn't even speak. So just because of, and she started losing facial expressions too. Anyway, I guess you'd have to go by blood pressure, something physiological there in the end. But don't, if they've had a stroke and they can't tell you, they can't speak to you, and they can't find the right word, how are you going to know? You got to watch, you got to find other clues. Values, the way people value themselves, one another, and the purpose and the purpose of any human interaction influences communication. So by that is, if I'm trying to get you to go along with a goal that I have to make you better and you don't buy it, you aren't going to do it. So it also has on here, as nurses, we convey that we believe in our values, and a patient's motivation or lack of motivation also influences the nurse-patient relationship. You can't get frustrated, and they can get frustrated. So we have to all be kind of on the same track. Then for environment, a calm and non-threatening environment is most conducive to communication. So we want to minimize distractions and ensure privacy. That will help a person to open up, and you don't want them distracted by environmental noise, let's say, hammer going on in the back. I'm thinking about patient teaching, and you got to make sure that the atmosphere is just so, when you go into teacher, they're not going to listen. So now we're going to talk about a communication tool called the S-bar, which I know you guys know all about this, but let's just do a review. So the methods of the S-bar, I put the one that's up there in your book. This is in your textbook. So I have the Quality and Safety Education for Nurses, which is QSIN, and we'll talk more about them. Institute identifies quality and safety competencies for nurses with the goal of preparing future nurses with the knowledge, skills, and attitude necessary to improve the quality and safety of the healthcare system. Woo, that was a bunch. QSIN provides teaching strategies such as the SBAR or the ISBARR. Some people add extra on there. Learning a standardized framework like the SBAR can help reduce perceived anxiety. It increases confidence related to the handoff reports. And the ISBARR is different between nurse to nurse, nurse to physician, and nurse to facility. And that's true. You wouldn't want, if you're doing the ISBARR, where I stands for identify, where you identify yourself, if you're switching shifts with somebody you've worked with for the last 10 years, you don't have to identify yourself. So you don't have to put that part on there. But if you're calling a facility, long-term care facility, that you're sending somebody there, or you're speaking to a physician, you need to identify yourself. Or any healthcare provider, doesn't have to just be a physician, but you need to identify yourself. Okay. Now we're going to talk about the helping relationship. So the helping relationship is between nurses and their patients. It's the nurse-patient relationship. That's what we've been talking about. That is the helping relationship. We are helping them to heal, or helping them with whatever our role is at that time. It's a professional relationship, not a social or personal relationship, and that's the way we have to keep it. The nurse is the helper, and the patient is the person being helped. This relationship is incredibly important as it affects all aspects of patient care, and we're coming into that trust word again. Remember, your patient is vulnerable, they're sick, they don't feel good, they're scared, they don't understand the lingo, and they're looking to you to keep them, to help them while they're there, to provide for them, to advocate for them, to be their voice. They're looking to you for that. So I'll let you go ahead and read that. What's on the rest of the sign here. Phases of the helping relationship. We have an orientation phase, a working phase, and a termination phase. So the orientation phase is where you establish tone and guidelines, you identify each other by name, you clarify roles, and establish agreement about relationships. Orientation to the healthcare system, to the room, whatever situation you're in. If you're the home health nurse, your schedule, etc. I've got an example that says, the patient will call the nurse by name. Patient and nurse will establish an agreement about goals and the duration of the relationship, etc. So you could walk into their, say we're a home health nurse. Hi, I'm Vicki. I'm going to be your nurse for the next week. I'm going to be showing you I'm going to be changing your dressing and showing your partner how to change the dressing as well, so that you guys can take care of that after our week is up. That's just an example. So see, I let them know. I should have said, Mr. Jones, I'm Vicki, blah, blah. But my point is, I don't want to blow this off. I don't mean it like that. My point is that we come in, we introduce ourselves, we tell them what we're going to do, and that lets them know how long this relationship is going to last, and that it is a professional relationship. So then there's the working phase. So this is where we meet the patient's needs. We assist or teach, counsel, whatever it is that they need, and we're there to do. Example is patient will actively participate in the relationship. Patient will express feelings and concerns to the nurse. So let's say we're doing that dressing change thing and it looks complicated to that patient or that patient's partner. And now we're in the working phase and they're saying, you know, Vicki, I don't know if I can do that dressing change or not. I'm really kind of worried. Well, that's when I could jump in and say, well, here, I've got a video for you to watch. I have written down instructions. I will be with you and take you every step of the way before I ever leave this. I'll just show you the first couple of days. I'll show you how to do it. I'll do it and I'll show you. And then the next 3 days or 4 days or whatever we have left, I will stand right beside you while you make that dressing change. And I promise you'll be a pro before I leave. And see, that way the patient gets to express their fears, not feel dumb about it. They feel comfortable because you make them feel comfortable. And then you make sure they understand how to change it before you ever leave. You don't ever leave them unsure, and then they'll be fine. Then we have the termination phase. So we evaluate our goals. If we've met our goals, it's been 7 days now that I've come, and the partner's a pro at it. By golly, they could tell me how to do it. So I see that I've done a good job. Now, what if they weren't? What if they were still really nervous? Well, then I might be able to call the doctor, ask for another visit. I would certainly say, why do you feel so nervous about it? I've watched you 4 times now, and you are really doing a good job. What is it that makes you feel unsure? Or it might be something so simple as I could say, here's my phone number. You call me. You call me and we'll FaceTime or Zoom or whatever it is, Messenger. Well, you call me and I'll help you out. Maybe something that easy. There does have to be a termination, though. So we discussed the plan for the future, like I just told you. And this example here in your book said, patient will participate in identifying the goals, verbalize feelings about termination of the relationship. Because it does have to end. It does have to end. But we just want to, sometimes it takes a little bit to push the birdie out of the nest. Okay, factors that promote effective communication. Well, we have dispositional traits and we have rapport builders. And let's just go through a few of those. Now, we know from the last slide, warmth and friendliness, openness and respect. You have those dispositional traits, you treat a patient like that, they're going to feel so good in your care. And empathy, we may not know what everything feels like, but I always say, if I don't know what something feels like, I'll say that. I don't know exactly how you feel, but I have taken care of people that have been in your situation or similar situation. I remember how hard that was on them. And see, that way, they know that I have that type of empathy. Honest authenticity and trust. If you need to go look something up for that patient, don't you forget to go back there and give them the answer. Just like you guys expect that out of me, because I don't know everything. I'm going to have to go look stuff up. If I didn't come back, you would think, what a rat. So make sure that you're true to your word. Show your caring, competence. We want to make sure that they see we are competent. Even if we are nervous, we want to make sure we display an air of confidence because that makes them feel better. And genuineness. Be yourself. Be yourself. Be your kind self. Rapport builders. Specific objectives. We'll tell them specifically what we're going to do. Provide a comfortable environment. You guys know these things. Make sure that the area is private. People like privacy, confidentiality. For the patient versus tasks, what I want to tell you about that is sometimes we are so task focused, at least I know I am. I am a task nurse. That I don't want to say I forget the patient, but I'm just so focused on that task. And we got to remember, task is great, patient care is where it's at. That patient's got to feel like they are that important to us. And you know what? When you're sick, you want to be number one. That's it. Or you're scared, or you're getting ready to have surgery. You want to be number one. And we got to make them feel that way. Let's see, utilization of nursing observations, optimal pacing, and providing personal space. All of those help a person feel good when we're there taking care of them. Developing conversational skills. We've talked about all of this all along, I think. Control the tone of your voice. I tend to get excited, and then what I do, I yell. So you got to control your voice. Be knowledgeable about the topic of conversation. That definitely makes a person feel comfortable in your care. So if you don't know a lot about what they're having done, make sure you read up a little bit before you go in there. Be flexible. Nurses are always flexible. Clear and concise. To the point. Don't go on and ramble. Avoid words that might have different interpretations. There are words out there that are colored differently that you have to be careful about. I'll give an example of, not that we'd use this, but calling a woman a broad. Broad is the side of a barn. That's a terrible, terrible word to use. But avoid words that might have different interpretations. Be truthful. Keep an open mind and take advantage of opportunities. When your patient looks like they are ready, say to learn something. Now, they've been really, really sick. They haven't talked much. They feel great today or really much better. Now's the time to slip some education in. Developing listening skills. Here's a whole bunch to this too. I'm pretty much going to read off this slide. Sit when you're communicating with the patient. See how she's sitting with him. She's not lording over him, and that is very comforting. That keeps a person, you're at the same level. Be alert and relaxed. Take your time. Don't rush through. Have you guys ever been to see a doctor or anybody, and they just, what I hate is from be looking at a chart, looking at their phone, looking at something else, and they're not listening to me. They're not looking at me. When I worked with Dr. Greenberg, one of the things I loved about her is she would come into the room, she would put the chart down, she would get right in front of you, not in your face, just sitting right in front of you, and she'd say, okay, what brings you in today? Looking straight at you. And she would not take her eyes off that person till they finished speaking. Keep the conversation as natural as possible. Maintain eye contact if it's appropriate for the culture. Now, if you're looking at somebody and they look away and they're a different culture than ours, don't be offended. Use appropriate facial expressions and body gestures. I don't want you to be paranoid now because we can't know everything. Just be yourself. Think before responding to the patient. Think the question over. Don't pretend to listen. Listen for themes in their comments that might cue you into what might be wrong or, more questions that you need to ask. Use silence, therapeutic touch, and humor appropriately. Let me tell you, I always have a story. Hey, I'll save that story for when we're discussing this, so remind me, I have a story. Okay, interviewing techniques. Oh my goodness, look at all those. Open-ended, closed, validating, clarifying, reflecting, sequencing, and directing. So I've got an answer for all those. Open-ended questions, of course, give you the widest range of possible responses. They always tell you. Use an open question. So here's an example from your book. The nurse says, what did your healthcare provider tell you about your need for this hospitalization? And then the patient says, well, he told me that my blood pressure was dangerously high and then I need some special tests done while I'm here. So a closed question or comment, which is a limited response. You're not going to get anything but yes or no. But sometimes we need those, though. What's the medicine you have been taking at home? And the patient says, I take a water pill and a blood pressure pill every day. So here's a validating question. The nurse says, at home, you've been taking both water pill and blood pressure pills every day. Did you take them today? And the patient says, yes, I took one of each with my breakfast. So that validates her question. Clarifying question. Sometimes these have muddy waters to me. The patient says, I have never needed to take medication before in my life. And the nurse says, is this the first health problem you've had? And the patient says, why, yes, I've always been healthy. So now we've got a reflective question. Patient says, I've been really upset about my blood pressure and having to take these pills. And the nurse says, you've been upset? And the patient says, I guess I'm worried about what could happen if my blood pressure gets too bad. And then we have a sequencing question. The patient says, I don't feel like myself anymore since I've been taking blood pressure medicine. I'm tired and I don't have any energy. He's probably on a beta blocker. And the nurse says, your tiredness began after you started taking your medicine? And here is a directing question. The nurse says, you mentioned your dad earlier. Did he develop complications related to high blood pressure? Aha. And the patient says, yes. And the nurse says, well, what sort of complications? And the patient says, kidney failure. He was on dialysis for years before getting a transplant. And the nurse says, are you afraid this might happen to you? So you see how that is? That gets that patient to open up, and that's what's the bottom line is. It's not he doesn't want to take his blood pressure medicine. He's just scared based on an experience. And Our patients, all of us, are products of our experiences throughout life. Basic components of assertiveness. Assertiveness is something that's very hard to do, but it's a very good skill to have. So, basic components are having empathy. We just talked about that. Describing one's feelings or the situation, clarifying your expectations, and anticipating consequences. So, the point is that you can speak to somebody about a situation, not be yelling, not be scared, not be upset, and just have a conversation. Here's a video, too, of dealing with an angry patient that's pretty good. It shows you both the right way and the wrong way. So we got a whole list of blocks to communication, and I'm just going to hit a few of these. You should be familiar with all these. Failure to listen. That's the worst one, I think. Maybe the worst one. I sure hate it when I think somebody is not listening or patronizing me. Hate that. Using closed questions. We just hit on that. You can't get very many answers or find out very many situations if your questions are all yes or no. Using questions that probe for information. That is different than directing questions. Directing questions, that nurse was trying to find out, why is this guy upset over taking his blood pressure medicine? A probing question would be asking a question about him that had nothing to do with his blood pressure. You're just being nosy. So you don't want to do that. And people know you're doing that. Using leading questions, that just gets you the answer you want. Those are no good. Giving false assurance. You never want to tell somebody everything's going to be okay when you don't know if it is or not. And it's so hard not to do that. I know, I understand, because I want to make people feel comfortable and safe and not so scared. And I want to say things like, it's going to be all right. But I don't really know that. So don't do it, because when it's not all right, then they hate you for that. They hate you. Don't change the subject. If somebody wants to talk to you about something, you're going to have to face it and talk to them about it. If you don't know about it, say that. I don't know. I got to go find out. Or I'm uncomfortable with this. I'm uncomfortable with this conversation and I don't feel equipped to talk about it. Let me find somebody who is. Make sure you say, but don't just change the subject. Gossip and rumors, we all know about that. Okay, we hit some of those. Oh, we're all done with therapeutic communication. Let's roll right into nutrition. Want to? So there's 6 classes of nutrients. You guys know this already. So the nutrients that supply energy: carbohydrates, proteins, lipids. The nutrients that regulate body processes: vitamins, minerals, water. Let's find out more. Alrighty, here is carbohydrates, and I have split these for you. Just give you an idea of simple carbohydrates and complex carbohydrates. You probably already know this. Complex carbohydrates have more fiber in them, and that makes your body metabolize them a little bit slower. They're not in the simplest forms. And then simple carbohydrates are in the simplest form and are absorbed almost immediately. Now, this does show, it shows chocolate as a simple carb, and it may be in respect, but if you're going to give a person with diabetes that has low blood sugar, don't give them a candy bar, because the fat content is usually too high. If you have too high of a fat content, it won't get absorbed into the bloodstream as quickly as you need for a low blood sugar. Orange juice, on the other hand, that's been taken, the pulp's been taken out, or for the most part it has. Now that'll get in your bloodstream right away. So sugars and starches, simple or complex, it's made of carbon, hydrogen, and oxygen. Our tissues need energy, need carbohydrates for energy, especially tissues like the brain. It is the structural framework of plants, but lactose comes from an animal, comes from the cow, and that is also sugar. There's about 12 grams of carbohydrates or lactose sugars in an 8-ounce cup of milk, regardless of whether it's skim, whole, or 2%, or chocolate. So most abundant, carbohydrates are the most abundant, least expensive source of calories, and that's why there are many, many countries where that is really the staple. It's converted to glucose for transport through the blood, so it can get to all the tissues that need it. It's oxidized to provide energy, carbon dioxide, and water, and about 45 to 65% of total calories is recommended by the RDA, recommended daily allowance for an adult. Of course, that stuff changes with pregnancy and children and elderly, your need for it. Next, we have protein, and it's required for the formation of all body structures. Remember, protein is the building block, and animal proteins are considered complete proteins because they have all 22 essential amino acids. An incomplete protein means it's missing one of those at least one of those amino acids. But you can take, plants are incomplete proteins, and you can take two of them to put together, and that'll make a complete protein. And the exception, of course, is soy. It is a complete protein. Hey, oh, sorry guys, I have a house full of cats, and one of mine is laying on the floor right now. Wish I could show you his picture. It's Vinny. He's Italian. So protein tissues are in a constant state of flux, and what they mean by that is we're metabolizing. Tissues are remade, and they're broken down, they're replaced constantly, and that's catabolism is the breaking down, and anabolism is the tissues being replaced, or the cells. So the recommended daily allowance for adults is 0.8 grams per kilogram of body weight, which that equals out to about 10 to 35% of the total calories that we take in every day. Then we have fats. Fats are what makes food taste good. And, I read a book one time that said, and I thought about this with oatmeal. If you make oatmeal, it smells one way. And then when you put in a tablespoon of butter, oh man, all of a sudden it really smells good. So fats are insoluble in water and blood. 95% of lipids in the diet are called triglycerides. Saturated fat means that it's solid at room temperature. Unsaturated fat means it's liquid at room temperature. Digestion of fats occurs largely in the small intestines. Fats aid in the absorption of fat-soluble vitamins, and that is very, very important. It provides insulation, structure, and temperature control. So think about the elderly when they're older and they have lost muscle mass, and often they've lost fat too, and they're so cold all the time. Fats are most concentrated source of energy. Carbohydrates and protein each have 4 grams, and fats are 9 grams. And the recommended daily allowance for saturated fats, remember that's the one that stays solid at room temperature. That can really hurt you with cholesterol and plaque. So 10% or less. And then little to no intake of trans fats. A person should try as hard as they could to never ever take in trans fats. You don't need them. It's hard though if you like things convenient. So here's a question. What's the name for the product that occurs when manufacturers partially hydrogenate liquid oils? What's the name of the product that occurs when manufacturers partially hydrogenate liquid oils? It's triglycerides. It's trans fats. Whoop! The rationale is trans fats occurs when manufacturers partially hydrogenate liquid oils. Trans fats raise serum cholesterol, and lipids are fats in the diet. Triglycerides are the predominant form of fat in food and the major storage form of fat in the body. I must have a ton of them. Cholesterol is a fat-like substance found only in animal products. And remember, our liver makes cholesterol too. We really would never have to eat any extra cholesterol. Okay, vitamins. Vitamins are organic compounds needed by the body in small amounts. Most are active in the form of coenzymes. They're needed for metabolism of carbohydrates, proteins, and fats. They're water-soluble or fat-soluble, depends on what the vitamin is. And they're absorbed through the intestinal wall directly into the bloodstream. And so then I've got some listed over here for you. Vitamin A is beneficial in treating eye disorders. You probably know this. B9 for neural tube defects. B12, relief from symptoms of anemia. You can have a B12 deficiency anemia. We'll talk about that in a little while. Vitamin C, scurvy, etc. So here's another question for you. Which of the following vitamins affects visual acuity in dim light, formation and maintenance of skin, and mucous membranes, and the immune function? A, D, E, or K? Which of the following vitamins affects visual acuity in dim light, formation and maintenance of skin and mucous membranes, and the immune function. Well, if you guessed vitamin A, you got it right. Vitamin A affects visual acuity, skin and mucous membranes, and immune function. Vitamin D provides calcium and phosphorus metabolism and stimulates calcium absorption. Vitamin E is an antioxidant that provides vitamin A, I can't read today, that protects vitamin A. Vitamin K helps the synthesis of certain proteins necessary for blood clotting. And then we have minerals. Minerals are organic elements found in all body fluids and tissues. They provide structure in body, regulate body processes. There's macro minerals like calcium, phosphorus, and magnesium, which we'll talk more about, and micro minerals like iron, zinc, manganese, and iodine. And of course, there's water. My goodness, we need water, water, water. 50 and 60% of adults' total weight is water. Look at that kitty. 2/3 of the water in our body is contained within the cells, which is your intracellular fluid. The remainder of body water is extracellular fluid, body fluids such as plasma, interstitial fluids. Water is a fluid medium that's necessary for chemical reactions. You must have water. You know why? My cat disappeared for a week, and I was so scared that he wouldn't make it, and he was in someone's crawl space, but it was a leaky crawl space, and there was water in there. So I read up, and it said a cat can make it 3 days without water, 7 to 10 days maybe without food, and it was Vinny. He's a Snoop. Anyway, he looked awful, but he had that water to drink, and that's what kept him alive. Humans can go a little bit longer. And water acts as a solvent and aids in digestion, absorption, circulation, and excretion. So every time you go to the bathroom, you should come back and drink a glass of water. So tell whether the following statement is true or false. Food is more vital to life than water because it provides the medium necessary for all chemical reactions, and it is not stored in the body. Is that true or false? Food is more vital to life than water because it provides the medium necessary for all chemical reactions, and it is not stored in the body. False. If you answered false, you're correct. Water is more vital to life than food because it provides the medium necessary for all chemical reactions, and it is not stored in the body. So factors affecting your basal metabolic rate. You knew we were going to get to that. Males have a higher basal metabolic rate due to larger muscle mass. They also burn more calories faster than us, and that's why it appears that they lose weight faster than us, because those muscles use up much more energy. And then that gives you the formula. So factors that increase basal metabolic rate: growth. If you're growing, you're burning up many more calories because you're metabolizing at a faster rate. When you have an infection and your body's working to get rid of it, your BMR increases. Fevers do that. Emotional tension, stress can do that. And extreme environmental temperatures. So if you went from freezing cold to hot, that's because, just think, if I'm right here today in my house and then I went someplace really cold, like in a freezer, my body's going to be going 90 miles an hour trying to warm itself up, and that's going to make the basal metabolic rate increase. And then certain hormones can do that as well. So factors that decrease the BMR would be aging. As we get older, our basal metabolic rate slows. Prolonged fasting. After a while, your body is going to go as slow as it can to keep you alive as long as it possibly can. And then sleep. You don't need to have as much energy when you're sleeping. You guys remember all this. Factors affecting food habits. There's physiological and physical factors. The stage of development and the state of health and medications. Let me see what I got up here. I have infants experience rapid growth and nutritional needs greater than any other time in their life. Toddlers feed themselves and express food likes and dislikes and often are too busy to eat. Adolescence is another time of rapid growth as well, growth rate as well as intense physiological growth. And they tend to skip breakfast and eat lots of junk food. That's because they're too busy. Remember being a teenager, you're too busy. Adults experience a decline in BMR with each decade. Lovely. Pregnant and lactating women need extra nutrients, and that's because they're forming a baby. And so it takes a lot more energy, of course, to do that. And then lactating, that's extra as well. The quantity of breast milk produced depends on an adequate supply of nutrients. So older adults have continued decrease in BMR, and they also have a decrease in peristalsis, which, remember, that's the movement of food through the body. And that then causes them to have constipation. They can also have a loss of taste, which makes them not want to eat. Decreased sensation of thirst. They become then more dehydrated, and their caloric needs decrease. Let's see here. Okay. Risk factors for poor nutritional status. We talked about developmental factors earlier. Actually, we may have just hit on these already. Little kids don't eat as well, and older people don't eat as well. And men and women may have different eating habits. Well, I can just tell you, and I don't know if this is true for everything. I don't think anything's absolute. Well, we know that men have a higher need for calories because they have a higher muscle mass than women do. And then we already talked about pregnancy and lactating. State of health. If you're sick, you don't feel like eating. I just had a friend recover from COVID-19, almost killed her. And she said there was a point where, of course, she was struggling to breathe. The last thing in the world she could think of was eating. And they said, you got to have something to eat or we're going to put a feeding tube in you. And she was just forcing herself to eat something. So state of health. Alcohol abuse. I had a stepdad who was a drunk. And he would get up in the morning and have a cup of coffee and put in a shot of whiskey. He didn't eat any breakfast. I only saw the man eat every now and then. And he had a big old pot belly on him, like some children that you've seen before that in those commercials, that show those kids over in third world countries with those little pot bellies. That's what he looked like. I'm sure he was lacking in all kinds of vitamins and minerals. Medications. Some medications can cause you to have a bad taste in your mouth, just make you not feel like eating. And then mega doses of nutrient supplements. That can also cause you, let me see what I put up here about that. I wrote a whole bunch about all that. Meds can change the pH in the GI tract, increase or decrease GI motility. Megadoses of nutrient supplements. An excess of one nutrient might lead to the deficiency of another. An example in the book was if you increase zinc, that causes a decrease in copper. Some supplements have a drug-like effect, and so then you always think of St. John's wort. It has an effect. It's like an SSRI, serotonin reuptake inhibitor. Anyway, it's like Prozac. So if you're already taking Prozac, you wouldn't want to take St. John's wort. Components of nutritional assessment. We've got to do an assessment. So we're going to do history taking, physical assessments, and collect some laboratory data. I did want you to know, too, to remember that anorexia means that lack of appetite, not the disease. And then you'll want to be familiar again with the BMI tables. So we take a dietary history. We ask them, what do you eat in a 24-hour period? Lots of times we do a 24-hour recall. And then most of this we've already talked about. Any medical problems, any socioeconomic problems, data, we would, if you can't afford to buy good food, you're not going to buy it. Remember that time when those elderly people, gosh, I think this was in the 80s. You guys may not remember that, but it was in the news. This poor lady was so poor. She was buying dog food and eating dog food. Alpo. So that has a lot to do with, we can preach all we want to somebody about you need to eat this and this and this and this. If they don't have the money, how are they going to buy it? So you know what? I mean, I know the dietitian's going to really pretty much take care of these people, but if we got to come up with something, we need to come up with something based on what they buy. Try to help that way. Physical assessment. This anthropometric and clinical data. Let me tell you about that. Anthropometric. It is the measurement of the size and proportion of the human body. So it's used to determine the body's dimensions. And an example is, in children, growth rate is what they use. In adults, it's an indirect measurement of the body protein and fat stores, such as height and weight. Or if you had calipers and you could do a tricep skin fold measurement or a mid-arm circumference, that all fits under the anthropometric data. And of course, clinical data is the data we're gathering. Our vital signs are clinical data. And then labs, we check blood glucose, cholesterols, blood cholesterol, triglycerides. You see on their protein status, we can check and see what your albumin level is or your protein levels, the vitamins and minerals in your body. We could do a CBC and see what your iron stores are like, etc. And ferritin would be exactly iron, but you know what I'm trying to say. Hemoglobin, hematocrit. Okay, factors to assess for nutritional status. We kind of hit on this already. 24-hour recall method. There's food diaries, calorie counts, food frequency records, diet history, etc. See if there's any allergies, any foods they can't tolerate. How do they cook them? How do they cook food at home? What's their storage practices? Is there anything they're not allowed to have? Any eating disorder patterns? Now that's where if they have the disease anorexia nervosa, that's the disease. But the idea of having anorexia, it just means you have a lack of appetite. But what if they were bulimic? Are they bulimic? Here's food guides, and that shows you the My Plate, which is, I think, excellent. If anybody, now don't get you a big whopping 16-inch plate. Get you one of those, 10-inch plate, and divide that up like that. And you would always be eating healthy. Here is some nursing interventions. What can we do to help? We want to tailor our nutrition instructions individually to the patient's lifestyle, like I just talked to you about, culture, intellectual ability, etc. Screen patients at home for nutritional risks. Observe intake and appetite. Evaluate patients' tolerance and assist them with eating if they need it. Administer enteral and parenteral feedings, consult with a dietitian and a physician, address potential, these are just several of these, address potential for drug nutrient reactions, obtain more food or snacks if they need it, monitor the food that's brought in, and participate in nutrition education efforts. So, sometimes people just don't know about nutrition, and if you can teach them a few things, that makes all the difference. Arranging a plate to look attractive, if that's in your control, can stimulate a person's appetite. Making sure you get the foods they love can stimulate their appetite. When it says assisting with eating, sometimes a person cannot. I think of my mom in the nursing home. She got to a point where if you didn't sit down and feed her, she wasn't going to be able to eat. She couldn't do it anymore. And so, and it takes a long time because she was eating very slowly. Well, you can just see how that might be compounded if a place is short of staff and you got 10 feeds and, 2 people. You can see how hard that'd be to make sure that was done, especially when it takes them such a long time to be able to eat. Providing oral nutrition. These are different diet types, and you should probably be familiar with those if you aren't already. Short-term nutritional support. So remember the NG tube. So brush up on the NG tube. Using the nasogastric or the nasal intestinal route. I have not taken care of very many nasal intestinal routes. Usually it's an NG tube. Confirming the NG feeding tube placement. So let me read you what I got up here. Enteral nutrition involves passing a tube into the GI tract to administer a formula containing adequate nutrients. You guys may have all done this. It's not suitable for people at risk of aspiration, if they have a dysfunctional gag reflex, if they have gastric stasis, GERD, nasal injuries, or they can't have the head of bed raised. That's the NG tube. The NI tube, which is that nasointestinal tube may be a better fit for somebody like that, and it's usually less than 4 weeks. So we confirm the NG feeding tube with radiographic examination. Before we use it, we measure, when we place it and before we use it, we measure and aspirate the pH, and we do a visual assessment of the aspirate. Measure the tube length, and that should be recorded, and every time you should measure that, marking, and the tube marking. Carbon dioxide monitoring if it's warranted, and confirming the nasointestinal tube placement. Long-term nutritional support. Well, now we've got a PEG tube that we're putting in, or a G tube, which is really one and the same thing, percutaneous tube or gastrointestinal tube. There it is, PEG tube. It says percutaneous endoscopic gastrostomy, or, well, they're not telling you about the G tube, but you've got some pictures there what it is. An enteral stomal tube may be placed through an opening created in the stomach or into the jejunum. A gastrostomy is preferred route to deliver enteral nutrition in a patient who is comatose. Placement of the tube into the stomach can be accomplished by a surgeon or a gastroenterologist via a percutaneous endoscopic gastrostomy PEG tube. So they can either do it surgically or with a scope. And that's the end of this. We are done. Okay. I thought that was so cute. All right. Well, next up looks like is inflammation and infection. All right. Thanks, everybody.